Ashwaq for the introduction, and also to thank the organizing committee for the invitation to talk about the role of next generation sequencing in hepatic and pancreatic malignancies. So what's next generation sequencing, or the other name for it is massive parallel sequencing, and it's an NGS technology that has the ability for high throughput sequencing of large number, up to millions of DNA templates or genes in a single reaction with multiple patient samples. So you can hundreds of genes, multiple patients at the same time. So really this will cut short the time for the results, and also you can sequence large number of genes, and therefore you will save DNA and tissue when you want to perform the test. So it facilitates screening of multiple genes with limited starting material, especially nowadays with most of the biopsies that we receive in pathology are core biopsies. So there is a significant advantage over the conventional sequencing platforms, which usually require relatively large DNA, especially if you want to test for 3 or 4 genes. If you do the single gene test, you need like 3 or 4 slides for each gene. So this will exhaust the tissue. But when you do all of them at the same time in a single reaction, of course, you will save tissue definitely. So just briefly about application of NGS in general, just to know, I know what some of you are familiar with them, like the whole genome sequencing. So when we say whole genome sequencing, we mean the coding and non-coding regions, which is the exons and the introns. Actually, in oncology, we are interested in the coding regions, the exons, which usually they code for the protein, where most of the time we have the mutations. Non-coding regions, which are the introns, are usually where we have the big points or the gene rearrangements. So whole genome sequencing, usually we see it in constitutional diseases, metabolic diseases, and inherited disease as well. Usually in pediatric population, it's very common to perform the whole genome sequencing. Then you will hear a lot about whole exome sequencing. So here you will omit the introns, you are sequencing only the exome, which is the coding region. But again, this is not targeted. You are actually examining the exomes of all genes across all the DNA. So this will be, again, not useful, especially we are talking about limited tissue material, usually done on blood sample, where you have large amount of DNA. You'll hear about whole transcriptome sequencing. Here, you are targeting the transcript, which is the mRNA, the messenger RNA, and therefore you are sequencing the RNA. So this is what you call the RNA-seq, and this is where usually targeting or looking for the gene fusions and gene rearrangements. And then our test of interest, the targeted sequencing of cancer hotspot mutations, which we are interested in oncology, where we sequence only specific mutations you are interested on. And therefore, we focus our DNA on those mutations, and we omit the other genes which we are not interested in. So the advantage of the NGS, low DNA RNA input with high detection sensitivity. And as you can see, simultaneous screening of multiple genetic changes. So you're looking for single nucleotide variants, copy number variations, translocations in multiple genes in multiple samples, and you can get a report within 10 days. This is really the minimum. Some people, they can do it in 2 weeks, and I've seen some centers 3 to 5 days as well. This is a commercially available hotspot panel. It consists of multiple of 50 genes, screening up to 2,800 cosmic mutations across 207 amplicons. So this is a limited panel focused on the commonly encountered mutations. And in common cancer, for example, lung, where you are looking for the EGFR, for example, in gliomas, IDH1, IDH2, kit for GIST, melanoma, where you're looking for BRAF, NRAS, and kit as well. And of course, colon, KRAS, NRAS, and BRAF. So these are for common cancer. This is a modified panel. We perform it in our translational pathology laboratory at the King Abdulaziz Medical City, where we have about 58 genes, including 35 genes looking for mutations, and we have 23 genes looking for gene rearrangement. So at the same time, instead of sending for sequencing and FISH, in the same test, you are doing gene rearrangement for ALCROS1, RIT-MET for lung, at the same time, EGFR at the same time. This is even a larger panel. This is seen commercially, like in Foundation 1 or Foundation Medicine, where you have mutations in 325 genes, and you are looking for gene rearrangement in about 25 genes. And the advantage, you can even look at the loss of heterozygosity, microsatellite status, and tumor mutation burden at the same time. So you don't need to send something for immunohistochemistry for mismatch repair genes. You can do everything at the same time. So now let's move to specific entities, which is focused in this masterclass, starting with hepatocellular carcinoma. So I usually concentrate on the common gene alterations, and I avoided to talk a lot about the name of the drugs themselves. I will leave it for you. So it's high refractory. It's known the HCC to most systemic therapies, but recently significant progress has been made in uncovering the genomic alterations in HCC, including potentially targetable aberrations. First of all, a brief introduction about common malignancies of the liver. We have the hepatocellular carcinoma, about 90%, and then cholangiocarcinoma, which is a bile duct neoplasm, 10 to 15%. And this includes intrahepatic, extrahepatic cholangiocarcinoma, and gallbladder cancer. The third entity, which is the fibrolamellar carcinoma, it's a rare tumor, which represents about 0.85%. This is very common in young patients, about 13.4% under the age of 40. So most of the targeted therapy are actually focused on those entities. Common genomic aberrations in hepatocellular carcinoma, they did genomic sequencing of multiple large number of hepatocellular carcinoma, and they were able to identify genes related to risk factor. For example, they noticed that the CTNNB1, TERT, and CDKN2A are common in hepatocellular carcinoma caused by alcoholic liver disease. So this is maybe a method of classification. TB53 mutations in hepatocellular carcinoma caused by hepatitis B induced cirrhosis, and other gene mutations that don't have distinct pattern, usually in patients with HCC due to hepatitis C, metabolic syndrome, and hemochromatosis. They were able also to identify genes that can demonstrate tumor staging. For example, TERT promoter mutations was seen more frequently in early stage tumors, while TB53 and CDKN2A alterations, as well as chromosome 11 amplicon, like FGF3, 4, 19, and or cyclin D1 stages. So based on the mutation, also you can see whether the tumor is in early stage or in an advanced stage. Common alterations according to signaling pathways that cause the cancer in hepatocellular carcinoma. The CTNNB1, exon 1, belonging to the WNT pathway. So you will see the color coding. This is blue usually. This is included in the small gene panel, and the red one only in the large panel, especially like the 325 genes. So accordingly, I will guide which best NGS platform you will choose. So in the WNT pathway, you have the CTNNB1, exon 1, TB53, of course, TB53. In chromatin remodeling, you have the ERID1A, ERID2, in addition to BAB1 and AZH2. Cell cycle, CDKN2A, cyclin D, cyclin D1, FGF3, 4, and 19. Epigenetic mechanisms like IDH1 and IDH2, and other genomic alteration include TERT, PTEN, and vascular endothelial growth factor, which is the angiogenic pathway, one of the really common targeted pathway in hepatocellular carcinoma. So this just briefly about them. And this is the proposed targeted therapy. For example, TB53, you have the bevacizumab, the ramucirumab, and sorafenib. The CTNNB1, there is a potent small molecular inhibitor in addition to exon-1 belonging to the WNT signaling pathway. CDKN2A and cyclin D1, you have the CDK4/6 inhibitor and the palbociclib, both of them. And then the common FGF3, FGF4, and 19, you have lenvatinib, which is one of the therapies included in the NCCN guidelines. So this is brief about common alterations in hepatocellular carcinoma and the maybe common targeted therapy. There are some inhibitors which are under the investigations like EGFR, mTOR, c-MET, and MYC inhibitors, but I didn't find really good studies about them. For me, I will choose the large panel for hepatocellular carcinoma because, as you have seen, most of the genes are not included in the limited panel. So I will choose the foundation one or the expanded panel. For intrahepatic cholangiocarcinoma, maybe mentioned in the recent presentations by our colleagues, IDH1, IDH2 mutations reported in 10 to 28% of cholangiocarcinomas, and they are associated with longer overall survival and were independently associated with longer time to tumor recurrence in multivariate analysis. In addition, of course, there is a benefit of targeting IDH1 mutation in advanced cholangiocarcinoma. BAP mutations seen in about 25% of cases, but I didn't find any targeted therapy for the BAP1. FGFR2 fusions, they have been shown to have enhanced susceptibility to FGFR inhibitors. And of course, nowadays, there's a lot of talk about the NTRK gene rearrangements, which is rare in cholangiocarcinoma, present in less than 1%. And they are better characterized in Asian patients compared to the Caucasian patients, plus KRAS and BRAF mutations, which are found in high tumor stage at the time of resection and more likely to have lymph node involvement and associated with worse long-term overall survival. So mostly mutations of prognosis rather than targeted therapy. So the advice really to whether you have resectable or unresectable. Unresectable, you get a biopsy, and resectable, if you're before you start NGS therapy, send something for NGS DNA and RNA-seq, looking for actionable mutations. If you detect them, consider the appropriate clinical trial. If not, standard of care. And if there is treatment failure for both, you start with the second line therapy. For intrahepatic cholangiocarcinoma, I will choose the limited panel because most of the genes, like FGFR2 and CDK or the IDH1 panel. For the extrahepatic cholangiocarcinoma, I didn't see a lot of really studies talking about the common alterations in the extrahepatic, but according to the comprehensive profiling, they were able to detect 4 molecular classes of extrahepatic cholangiocarcinoma. They call it metabolic class. They showed hepatocyte-like phenotype, so they behave like hepatocellular carcinoma, where they have activation of HN4A. Proliferation class, about 23%. This is common in distal cholangiocarcinoma. They're characterized by MYC targets and ERBB2, which is HER2 amplifications, and activation mTOR signaling. So this may be also in the future targets of therapy. The largest class was the mesenchymal class, defined by signature of epithelial mesenchymal transition, where they have aberrant transforming growth factor beta signaling, and it's a marker of poor overall survival. The class 4, which is immune class, 11%, they have high lymphocyte infiltration, and they have overexpression of PD-L1. So this is associated with better response to the immune checkpoint inhibitors. So this is mostly related to the extrahepatic cholangiocarcinoma. Moving to the last one in the bile duct or biliary system, the gallbladder cancer. The most really comprehensive study I found published in Annals of Translational Medicine, where they studied about 60 patients of gallbladder cancer. They extracted DNA from tumor tissue, and they did capture genomic alterations by ultra-deep NGS. And they discuss it in multidisciplinary tumor board before the clinical management. And according to their discussion, they will decide the genomic profiling guided targeted therapy, the GPTT. Their panel actually is even larger than the commercially available panel, about 450 cancer-related genes and 38 genes rearrangement. They were able to detect alterations, TP53, the most common one, not surprisingly, HER2, new, ERBB2, CDKN2A, PIK3CA, KRAS. They found also a role for the loss of heterozygosity and the microsatellite instability. For actionable gene fusions, they found FGFR-related fusions and also NTRK fusion events. The overall in their study, in about 76%, about 46 out of 60 patients, they will be able to detect, they match them with GPTT regimen. Among them, about 26, about 43%, almost half, they have more than one targeted genomic profile targeted therapy. So this is our summary of the detected alterations and their targeted therapy. But I will give you just a summary. Here, again, the limited gene panel will be able to cover all genes in gallbladder cancer. And in addition, if you want to do for microsatellite instability, we can do it for by immunohistochemistry if you want to avoid the expanded panel. So those are the common alterations and targeted therapy, the ERBB2, 3, or the HER2 amplifications, just like the breast cancer, trastuzumab, CDKN2A loss or deletion, the ribociclib, just like the one we talk about in the hepatocellular carcinoma, PIK3CA, also one of the targeted mutations, FGFR2 and 3 as discussed previously with the pazopanib and also leventinib. So for survival analysis, they didn't observe any prognostic significance for survival correlation with the CDKN2A or the ERBB2 with p-value 0.13 and 0.06. The last entity I will talk about here is the pancreatic cancer with common mutations, including the KRAS and EGFR. Lack of KRAS mutation was associated with increased survival on univariate analysis, whereas the EGFR status was not predictive of any response or outcome. The presence of KRAS G12D now gaining a lot of attention because of the potential targeted therapy with exosome or small extracellular vesicle loaded with small interfering RNAs. BRCA1, BRCA2 mutations is a multi-center phase 2 trial showing that PARP inhibitor can be used for treatment of patients with germline BRCA1-2 mutation. And recurrence cancer achieved with an ORR of 2.17% for pancreatic cancer. Microsatellite status also, there's updated guideline recommend Pembro immunotherapy for patients with mismatch repair or instability after failure of first-line therapy. Again, NTRK fusion now, most of solid tumor, if you are really desperate, the lactretinib and entrectinib also can be used as an actionable mutation. ALK rearrangement, the use of ALK inhibitor was also currently under investigation in this study. So this is summary of the target therapy. This is the one we talked about here. These are under investigation, targeting the MEK inhibitor, STAT3, and also the targeting the tumor metabolism. And I think this is the end of my presentation. Thank you very much.
So again,